Today we will discuss about abortion. Coming to the terminology, abortion is the termination of pregnancy less than 20 weeks of gestational age. According to WHO, the termination of pregnancy occurs and weight of the fetus is less than 500 grams. In case of early pregnancy loss, the abortion is less than 12 weeks. In case of pregnancy loss greater than 20 weeks, we call it as stillbirth. What is anembryonic pregnancy? It is a non-viable pregnancy with a gestational sac that does not contain yolk sac or embryo. An anembryonic pregnancy is diagnosed if the mean sac diameter is greater than or equal to 25 millimeters and no embryo seen, or greater than or equal to 11 days after the scan showing gestational sac with yolk sac but no embryo, or greater than or equal to 2 weeks after the scan showing gestational sac without yolk sac or embryo. The most common time for abortion is T1, that is less than 8 weeks. What are the risk factors of abortion? The two most important risk factors are increased maternal age, that is greater than or equal to 35 years, and previous history of abortion. What are the other risk factors? Maternal infections like syphilis, viral infection like parvovirus P19, Zika virus, and cytomegalovirus. Toxoplasma and HIV are not associated with increased risk of pregnancy loss. Maternal risk factors are uncontrolled diabetes, thyroid disorders like hypothyroidism, hyperthyroidism, obesity, stress, pregnancy with IUCD in place, substance abuse, and radiation. The types of abortion are spontaneous, divided into isolated and recurrent pregnancy loss. Induced abortion is MTP. Isolated abortion can occur at first trimester or second trimester. The most common cause of T1 and T2 abortion is chromosomal anomaly. The best answer is aneuploidy, followed by trisomy, followed by monosomy X, and followed by trisomy 16. Other causes of isolated abortion is uterine anomalies, fibroid, adhesion, septa, and cervical incompetence. Remember, cervical incompetence leads to T2 abortion and not T1 abortion. Trauma, infection including chorioamnionitis, maternal infection, torch infection, thrombophlebitis, isolated abortion. Three most common causes are chromosomal anomaly, uterine anomaly, and trauma. Important one-liners are most viable trisomy is trisomy 21, that is Down syndrome. The most outcome of it is abortion. Most lethal trisomy is trisomy 16. Coming to recurrent pregnancy loss, it is a greater than or equal to 3 consecutive pregnancy loss at less than 20 weeks. Investigation should begin not at 3, even if greater than or equal to 2 abortion. Causes, most common causes idiopathic. As a group, if we call causes, the most common causes endocrinological group, uterine group, immunological group, and chromosomal abnormality. Coming to the endocrinological group, the established causes hypothyroidism, and the others are uncontrolled diabetes, increased prolactin, luteal phase defect, and PCOS. These are not yet established. Coming to the uterine established causes, cervical incompetence, uterine malformation, submucous fibroid, Asherman syndrome. Immunological causes, established causes, APLA. Chromosome abnormality is established causes, balanced translocation of chromosome. Most common single causes, APLA. Infection do not lead to recurrent pregnancy loss, including TORCH. Syphilis follows Kasowitz law. That is, as the number of pregnancy increases, the period of pregnancy at which the loss occurs also increases. For example, if in the first pregnancy it leads to abortion, in the later pregnancy, that is second pregnancy, it will lead to stillbirth, and the third pregnancy, it will lead to preterm labor. We will move on to case. In case of G4P0, has presented with bleeding at 11 weeks. The investigation will be doing it as APLA antibodies, that is lupus anticoagulant, anticardiolipin antibody, anti-beta 2 glycoprotein, and TVS, Mullerian malformation, fibroid, and cervical incompetence can be picked at TVS. The investigation of choice for Mullerian malformation is 3D ultrasound, and the gold standard for Mullerian malformation is MRI. You have to do TSH investigation. It should be less than 2.5. Karyotyping of parents should be done. The test that is not done is torch test. Investigation should begin, as I said, that is greater than or equal to 2 pregnancy losses. Two most important investigation done in recurrent pregnancy losses, TVS followed by APLA antibodies. What is APLA syndrome? The antibodies are present against phospholipids. That is the three antibodies I mentioned. They cause arterial thrombosis, venous thrombosis, and placental thrombosis. Placental thrombosis can lead to abortion. There is recurrent pregnancy loss, stillbirth, IUGR, and PIH. Apla syndrome you can diagnose by modified Sapporo's criteria or Sydney criteria. You have to pass one lab criteria along with one clinical criteria. The clinical criteria is greater than or equal to 3 pregnancy loss at less than 10 weeks, greater than or equal to 1 pregnancy loss at greater than 10 weeks, greater than or equal to 1 preterm labor at less than 34 weeks due to early onset preeclampsia or IUGR, and vascular thrombosis. One lab criteria is the antibodies. If any of the one antibody is present in medium to high titer on two occasions 12 weeks apart. The management of APLA is in pregnant female is low dose aspirin started as soon as the pregnancy is diagnosed and given in all cases of APLA. Low molecular weight heparin is given only to patient if there is history of thrombosis and history of abortion only after confirmation of the intrauterine pregnancy. Management of APLA in case of non-pregnant female is warfarin. Uterine anomalies. You have congenital and acquired. Congenital is Mullerian malformation. Most common lead to recurrent pregnancy losses, septate uterus followed by bicornuate uterus. The acquired causes cervical incompetence. It leads to only T2 abortion. That is the most common, and followed by submucous fibroid, polyp, adenomyosis, and Asherman syndrome. Most common uterine anomaly causing T1 recurrent pregnancy loss or early recurrent pregnancy loss is septate uterus. For uterine anomaly during pregnancy, do TVS. In case of non-pregnant female, you can do investigations like saline infusion sonography for identification of polyp and fibroid. 3D ultrasound is an investigation of choice for Mullerian malformation. MRI is a gold standard for Mullerian malformation. You can do hysteroscopy and laparoscopy. Coming to cervical incompetence, it is the cause of recurrent pregnancy loss only in T2, as I said. Mid-trimester recurrent pregnancy loss never leads to T1 abortion. History-based diagnosis of cervical incompetence. The criteria is greater than or equal to 2 painless T2 pregnancy loss. If it is present, then it is a history-based diagnosis of cervical incompetence. Spontaneous dilatation of cervix, which is painless, and expulsion of products of conception occurs spontaneously. With every subsequent pregnancy, the time at which pregnancy losses occur goes on decreasing. It is opposite to that of syphilis. Risk factor for cervical incompetence, past history of surgery on cervix, like conization, leaps, and cervical intraepithelial neoplasia, cervical trauma during labor, during instrumental delivery, and congenital abnormality rarely. Diagnosis of cervical incompetence. I said the history-based diagnosis. If the history-based diagnosis is not present and history of only one painless T2 abortion is present, you should do TVS. TVS is done between 18 to 24 weeks commonly, but you can do as early as 14 weeks. Principle, as the cervix dilate, it becomes short. So on TVS, the length will be less than 2.5 centimeter. Diameter of internal loss as the cervix dilate will be more than 2 centimeters. Shape of cervix will be U-shaped. The relationship between internal loss and cervical canal determines the shape. Initially, it will be T-shaped. As the cervix dilates, it will become Y-shaped, V-shaped, and U-shaped finally. For ultrasound-based diagnosis, there should be history of 1 T2 abortion along with TVS. Cervical length is less than 2.5 centimeters. The treatment is cervical cerclage plus progesterone. Diagnosis of cervical incompetence in non-pregnant female is you have to pass Hager's dilator of number 8 through internal loss without the female offering any resistance. Note a female with cervical incompetence may present as a case of T2 abortion or as a case of early preterm labor that is less than 24 weeks. Management of cervical incompetence. The surgery is called as cervical cerclage. It can be done transvaginally most commonly. If transvaginal fails, you can do transabdominally. McDonald cerclage, try to reach the internal os closely. Apply stitch at cervico-vaginal junction. The suture is purse string suture. It is non-absorbable. Sirotkin cerclage is done at the level of internal os. As I said, transabdominal should be done only if transvaginal fails. Ideal time for cerclage is 12 to 14 weeks. Can be done up to 24 weeks. It is not done beyond 24 weeks. Suture material is non-absorbable. In all patients in whom cerclage is done, you have to supplement them with progesterone till 36 weeks plus 6 days. Investigation for cervical cerclage. The indication for cervical cerclage is it should be done if history or ultrasound based criteria is met. History of multipetal pregnancy has increased risk of preterm labor. It's not an indication for cervical cerclage. Coming to a case, a G2P1 pregnant female at 14 weeks for routine antenatal checkup. She has a history of one previous T2 abortion at 18 weeks of pregnancy. Then you have to do TVS. If it is less than 2.5 centimeter, USG criteria is met. So you will be moving on with treatment. If it is greater than 2.5 centimeter, then you will be doing serial USG to measure cervical length till 24 weeks, every 2 weeks. Case 2, G3P2 female at 16 weeks for routine antenatal checkup, history of 2 T2 abortion. Then it is a history-based diagnosis. You will be more proceeding to treatment, irrespective of the cervical length. Case 3, a G3P2 female at 18 weeks of pregnancy with no history of abortion and TVS and cervical length is less than 2.5 centimeter. There is an increased risk of preterm labor, so you have to give progesterone starting at 16 weeks until 36 weeks plus 6 days. In case for a female at 16 weeks comes with cervix dilator and membranes bulging. It is a physical examination based cerclage. You have to do a emergency cerclage. Therapeutically, even if it is done, it has a bad prognosis. Absolute contraindication for cerclage is fetus has gross congenital anomaly that is not compatible with life. Current pelvic infection, ruptured membranes. Relative contraindication is placenta previa. Time of removal of cerclage is 37 weeks. Cerclage stitch should be removed irrespective of the period of gestation is rupture of membranes, patient goes into preterm labor or chorioamnionitis. Types of abortion. You have threatened abortion. Threatened abortion is a process of abortion has started, but it is reversible. History will be spotting PV with or without pain abdomen. In per-abdominal examination, height of uterus will be equal to period of gestation. Internal os will be closed. Management is no definitive treatment. Empirical treatment is avoid heavy weight lifting, avoid intercourse, and rest for 48 hours. Anti-D should be given in RS negative females if threatened abortion is greater than or equal to 12 weeks. In ultrasound, we have cardiac activity present. Next type is inevitable abortion. Process of abortion reached a limit where it is not reversible. History is bleeding plus pain abdomen, no products of conception coming out. In case of para-abdominal examination, height of uterus is equal to period of gestation. As the product of conception is not coming out, the height is equal. Internal os is open. Management is you should complete the process of abortion by surgical or medical methods. Anti-D, you have to give anti-D to all RS negative females, but the dose differs. In case of less than 12 weeks, you should give 50 micrograms. In case of greater than 12 weeks, you should give 300 micrograms. Cardiac activity is absent here. Coming to incomplete abortion, it is a process of abortion begins, but the products of conception starts coming out here. History will be products of conception coming out plus bleeding plus pain abdomen. If the bleeding is more, shock can be a feature. For abdominal examination, the height of the uterus will be less than period of gestation as the products of conception is coming out. Internal os open and POC coming out. Management is complete the process of abortion. Anti-D is given to all RS negative pregnancy in incomplete abortion. In case of complete abortion, entire process of abortion is completed on its own. History is bleeding, pain, and POC come out with bleeding has stopped later. For abdominal examination, height of the uterus will be less than period of gestational and internal os will be closed here. Management is reassurance. Anti-D only if complete abortion in case of greater than or equal to 12 weeks. In case of ultrasound, you'll be having empty uterus. What is missed abortion? That is, the cardiac activity of the fetus will be stopped and the patient is not aware about the abortion. History is no history. Per abdominal examination, you'll be having height of the uterus less than the period of gestation, and the internal os will be closed. Management is expedite the process. Anti-D is given to all pregnant RS negative females. Ultrasound is the findings is in case of missed abortion is the mean sac diameter is greater than or equal to 25 millimeters and no fetal cardiac activity present. If the crown drop length is greater than or equal to 7 millimeter and no cardiac activity is present. Most common abortion leading to shock is septic abortion. And the second most abortion leading to shock is incomplete abortion. Approach to a case of abortion. First, you have to ensure whether the products of conception is came out or not. In both cases, you'll be doing a pervaginal examination, examining the internal os. If the products of conception came out and the internal os is open, it is incomplete abortion. If the products of conception came out and the internal os is closed, it is complete abortion. The products of conception not came out and the internal os is open, then it is inevitable abortion. If the products of conception didn't come out and the internal os is closed, then you have to following by a per abdominal examination. If the height of uterus is equal to per period of gestation, it is a threatened abortion. If the height of uterus is less than period of gestation, then it is a missed abortion. Thank you.